I thought we'd start by, we sent out a survey which we're very impressed a lot of people answered. I've got some of the results that we had towards the end of last week, and we'll go through those quickly. We won't have all the answers to the clinical scenarios at the start of the day necessarily, but I thought we could perhaps discuss them again at the end of the day. So what we're aiming to do today is talk a little bit about some definitions, what actually is an allergy, what is eczema, talk about some primary prevention strategies, so that's preventing disease before it occurs, and secondary prevention or treatment strategies as well. These are some of the results from your survey. So majority of people are coming here, work in a primary healthcare setting, got some secondary care and some others. Most of you are involved with education and management of patients and families. So we've got quite a few people involved with educating other health professionals, students, and also developing guidelines. And so hopefully some of the information that we give today will then be able to be filtered through to clinical practice for other people. We're interested to know whether people were using some of the resources that have been developed. The New Zealand Paediatric Society has set up a number of clinical networks for a variety of disorders. And there's a paediatric allergy clinical network which started about 18 months ago. And they've got some online resources, but unfortunately over 50% of you didn't know they existed. So I'll give you the website for those in a minute. Similarly, the Eczema Network's got some really good resources. Those of you who've used it may have found it helpful, but again, quite a few don't know about this, so it obviously feeds back to us that we need to do a better job of promoting these. ASCIA is the Australasian Society of Clinical Immunology and Allergy, so that's an Australasian organisation. They've got a very well-established website with lots of information on it. But again, about a third of you didn't know that those resources were available for you as well. So I've got the websites. They'll probably, we can probably get them printed out for you if you want later. So we asked a few case scenarios just to get an idea of what people were thinking about in terms of eczema and allergy management at the moment. So the first case scenario was a 4-month fully breastfed infant with some mild eczema and some cradle cap, and the mum was thinking about introducing some formula feeds. And so we asked you what you would do in terms of skin care, and very correctly the vast majority of people who answered said they'd use some moisturiser. Some were happy to use some steroid. In terms of the feeding of the infant, about a half were happy to say you can introduce cow's milk, but others were more hesitant, saying you should continue breastfeeding, should use hydrolyzed formula, or discourage introduction of solids at that age group. And about 2/3 said the mother should have a normal diet, and about a third suggested some food exclusions might be in order. The next case was looking at a 6-month-old who was already taking a mix of cow's milk formula and breast milk and had some mild eczema. We asked about introduction of solid foods, and the vast majority, probably 3/4, said normal foods could be introduced. A lot of people said as per infant feeding guidelines or as per Plunkett guidelines, so I thought that was quite good. Some suggested avoiding some foods, and again, people were very onto using lots of moisturiser. Some more people were happy using steroid. The third scenario was a bit more complicated probably. So this was a 3-year-old child with severe generalised eczema, had some skin prick testing which was positive to milk, egg, peanut, soy and wheat. We asked you what other information you would like to have, and it was pleasing that a lot of people said they needed to know more about what actually happened when they ate those foods, taking the history. Some people wanted to have specific IgE testing, and others said they didn't know what to do. It's okay. There's a range of answers which I tried to group into things based on what you'd recommend in terms of diet. Quite a few people, probably about, some people said either you avoid the foods that they're sensitised to, or you have to do a food challenge to those, or a trial of a food exclusion. Others said that avoidance should be based on the history results of the history. And again, some people didn't know. So hopefully this will be clarified during the course of today.
So, the straightforward definition of allergy is that allergy is an immunologic response. It's a response to something that you commonly come in contact with that's not normally a problem. And common examples, food, pollen, and other environmental allergens, to a certain extent venoms and medications, and you develop sensitivity to that. And I think there's a few definitions that it's useful. Atopy really is the underlying tendency of your immune system to become allergic. And if you took a population basis for that, so maybe about half of the population in New Zealand will have some tendency towards developing atopy. If you looked at that just by saying, well, what proportion of the population say are positive to something like dust mite. But atopy and allergy are not necessarily the same thing, and so allergy is really the clinical manifestation of atopy. And so if you think about the population at 100%, atopy being maybe 40 to 50%, and allergy, depending on what you're talking about, if that's allergic rhinitis, that might be 20% of the population. If that's food allergy, that might be 5 to 10% of the population. So you've got a big population, some of whom make allergic antibodies and some of whom have allergic disease. This is from a classification of adverse food reactions. It was in a really big publication from the National Institutes of Health in 2010. And there's quite a lot of resources on that site. There's a really big review document about food allergy diagnosis and classification. There's a summary document, and there's a layperson document about it, really just trying to explain what we're talking about. And so adverse food reactions can either be immune mediated, which is what we're going to talk about today, or non-immune mediated. So that's food intolerance, lactose intolerance, pharmacologic effects of foods. You can have this funny thing called scrombroid fish poisoning, where the fish is infected by something that then makes histamine, looks all the world like an allergic reaction, but it's actually just a toxin reaction. Whereas in terms of immune mediated, mostly what we're actually going to talk about today is IgE mediated food allergy. I think talking about non-IgE food allergy is much more complicated, and so I thought perhaps we wouldn't do much of that, hopefully. Types of hypersensitivity. I'm not really going to, so we're really talking about Jelen-Coombs type 1 due to IgE. And there are obviously lots of other ways of reacting to things immunologically, which may have a role in some of the other sorts of food immunologically mediated reactions, but are much more difficult to be sure about. So what does IgE do? So you've got mast cells in your skin and your gut. Mast cells have got receptors on them for IgE, and so the IgE sticks on the mast cell. And the mast cell is then primed, and if you meet the allergen that your IgE is made against and you cross-link all those IgE, then the mast cell will be stimulated and it'll release all of the mediators. You probably have to cross-link, they reckon about 100 IgE molecules per mast cell to activate that mast cell to trigger. And mast cells are kind of like bags of chemicals, and they release a whole lot of stuff that's immediately active. And I guess histamine is one of the things that you see effects of. So it's vasodilatory, it causes itch, and all the primary mediators of allergic reactions. And then stimulating the mast cell also activates arachidonic acid pathway to get secondary mediators of allergic reactions. And what we see from that are predominantly vasodilation, increased vascular permeability, so causing flushing and swelling and redness, smooth muscle spasm affecting the airway, and cellular infiltration as part of a late phase. The clinical effects, I think the thing about IgE-mediated reactions is that they have no unifying feature. You can have any combination of signs or symptoms, and you can have a different combination of signs or symptoms on different occasions. So there's no one thing that you're always looking at. If you're looking at anaphylaxis, urticaria occurs probably only 70% of the time. So it's really recognising a constellation of signs or symptoms, but manifestations commonly affecting the skin with some combination of itch, erythema, urticaria, gut manifestations, nausea, pain, vomiting, diarrhoea. The thing about food aversion, obviously lots of kids have food aversion to lots of foods, but we'll see a number of kids every year who have always refused to eat nuts because they don't like them, but actually they're allergic to them when they do get round to eating them. Respiratory stuff can either be upper respiratory, itching, sneezing, coryza, lower respiratory and or cardiovascular, and obviously it's these ones down here. You know, there's lots of definitions of anaphylaxis and it can be quite complicated what your definition is, but essentially it's the stuff that's going to get you into trouble, which is largely laryngeal, lower airway or cardiovascular manifestations. This is just the historical bit about allergy because I quite like it. So this is 865 AD in a Arabic text talking about the reasons why heads of people swell and produce catarrh at the time of the roses, which sounds like hay fever. 1565 referred to people who held the smell of the roses in deadly hatred because of the symptoms. And then there's this really interesting case series in 1828 labelled as, I don't speak Latin, but summer catarrh. And the reason it's interesting is that what John Bostock described is that the most remarkable circumstance to him was that he hadn't noticed this as a specific affection until the last 10 or 12 years, so that he was recognising the onset of a new manifestation. I mean, he also described that he hadn't heard of a single unequivocal case occurring amongst the poor, suggesting that even then there was some epidemiologic variability in that population. There's no doubt allergy is on the increase, and so these graphs, and there's lots and lots of versions of this, but this comes from a study looking at Finnish recruits into the military service with compulsory military service, looking over the years 1960 through to 2000. So you can see pretty clear, you know, this is using the same form on each occasion, and so rates of asthma increasing markedly, allergic rhinitis increasing markedly, and atopic eczema increasing quite significantly as well. So, you know, that recognition that allergic disease took off in the second part of the 1900s is pretty universally agreed, I think. And then this is one of the graphs from the ISAC study. So that's international study of asthma and atopy in childhood, and really just showing quite a marked variance by nationality in terms of rates of allergic rhinitis. And this is New Zealand in here, with several centres involved in this study, but allergic rhinitis affecting somewhere between 20 to 40% of, I think this is the 7 and 8 year old group. So really very common and different between different countries. I think it's really interesting to put it in the context of what other things have gone on over this same time period. And so this is a graph of changes in allergic diseases over the second half of the 1900s, with really remarkable drops in a range of infectious diseases, both related to vaccination and changes in living conditions. So essentially almost obliteration of measles, marked reduction in mumps, significant drops in tuberculosis and hepatitis. And that over this time period, it's not just atopy that's increased markedly, that autoimmune diseases have increased almost in parallel with allergic diseases over the same time period. So that's multiple sclerosis, Crohn's and type 1 diabetes, suggesting that that maybe all of these things are somehow tied together. And I think that's just what I wanted to have a little bit of thought about. I think one of the things that hasn't changed over this time period is your genes, because obviously that's pretty much the same. This is from a Melbourne birth cohort looking at the impact of having parents with allergy, and there seems to be a dose effect. So the top line in here is participants with at least one allergic parent, showing that by the age of 20, 43% of those participants had one or other manifestation of allergic disease in terms of asthma, eczema and allergic rhinitis, compared to those who had non-allergic parents, where it was about 23%. So your genes is definitely one of the things that comes into whether or not you're likely to get allergy. The unifying sort of idea about why we see more allergy than we used to. At about 2000, the hygiene hypothesis was proposed, and this was the idea that You've got different sorts of T helper cells in your immune system, and some of those T helper cells are good at generating inflammation, and some of those T helper cells are good at generating allergy. And that maybe with a change in infectious burden, we've skewed the immune system away from being really busy fighting infection to being allergic in nature. But it's become, I think, much more complicated than that. And the current kind of underlying premise about it is that there must be something to do with epigenetics involved in the reasons why all of these diseases are changing. And so we know that early exposures to a variety of different things, so to diet, to microbes, to toxins, to stress, to pollutants, to pretty much anything you can think of, changes the way that genes are expressed. And so this is done in a couple of different ways in terms of molecular modification. It doesn't change your genes, but it changes what genes are turned on. And so that will then result in later risk of disease, not only in terms of allergy, but also in terms of cardiovascular disease or autoimmunity, obesity, dementia. This is probably how we're thinking about immune regulation now in terms of the things that have an impact on the way your immune system is responding. Early in life, maternal body mass index, pre-delivery medications, mode of delivery clearly has a role in risk of atopy, breastfeeding has a role, daycare attendance has a role, and vitamin D, I've added the vitamin D to this because that's sort of been added since this went to publication. And then in adult life, cigarette smoke, allergens, infections, pollution, and a whole lot of other things can impact on your immune system. And the way they do this is they impact on the regulation of your immune system. So rather than thinking about this as being a Th2 mediated disease with that, you know, you're either a Th1 inflammatory or a Th2 allergic, the control of that is by cells called T regulatory cells. And they're influenced by a whole lot of different things. But one of the real key things is that the microbiome, so the bugs that are in your system, influence the regulation of your immune system. And they do that in a number of different ways, directly through the innate immune system. They do it via short-chain fatty acids, and they do it via the adaptive immune system as well. But to generally creating an environment where there's less pathogens, where there's less inflammation, and where particular antigens are removed. And so the strategies for allergy prevention are really going to be beyond just food. And this is from a slide of Susan Prescott's, who's at Perth, who does a lot of the sort of work about perinatal risk factors for not just allergic disease, but also other non-communicable diseases. Thinking about ways that we can make an impact on T regulatory function. And so one of that's reducing pollutants, reducing exposure to medications, changing the sort of microbial exposure that we're getting, returning to more traditional diets, both in terms of fats that you might find in fish, fibre and antioxidants, and then behavioural strategies including exercise, sun in moderation, and vitamin D. So what is allergy? Well, I guess allergy, number one, it's common, it's a significant cause of morbidity, and it's enormously costly to our health system. And it's largely a disease of developed lifestyles. It shares risk factors with a range of other non-communicable diseases that are associated with inflammation and immune dysregulation. And the next session is really thinking about preventative strategies, but hopefully that just sets the scene a little bit. So I'm happy to answer any questions if anyone's got any.
Yeah, just on that, drugs. I've seen a huge increase in willingness to prescribe reflux medications for babies.
Yeah.
And surely that's altering your pH and is there any link? Is that being looked at in studies or?
Yeah, it has, and there's definitely an association, but I don't think there's anything that no one's going to do a blinded randomised trial of it. So use of reflux medication is associated with specific IgE, and even actually in adults, use of omeprazole is associated with de novo specific IgE. So adults who've not had specific IgE against foods who've then had a period on omeprazole. So absolutely, it may be one of the things that's important. And you're right, it's used for everybody who cries. Yeah. And obviously, you know, we don't want to not treat those who truly need it, but we only want to treat those who truly need it.
So I guess it's a minefield because a lot of the people come to you saying my kid's spilling and vomiting, but could that be a manifestation of an allergy, or you don't?
I think unless it's obvious, it's probably not. I think if you've had 5 mils of cow's milk and you've got sudden onset of profuse vomiting, then I'm much more suspicious. But if you're just a generally vomity baby, you know, historically people have been very interested in whether if you change the diet, does that make a difference? Does cow's milk avoidance make a difference? The studies are pretty poor and they're incredibly confounded. So I think the answer is normally to try not to focus on the food. Yeah.
Have there been any studies on probiotic supplementation and allergic response, mitigation of allergic response?
Buckets. And I think the last Cochrane says, you know, the trouble with the studies is people have used different probiotics in different ways. So some through the last trimester, some through the last month and during breastfeeding, some postnatally only. There's definitely, and I don't know if you're going to speak about probiotics at all.
Briefly.
Yeah, I mean, there's a little bit of stuff from, in fact, the Wellington group's stuff about and a probiotic specifically whose name I can never pronounce properly. Yeah, rhamnosus, yeah. That seems to have some proven benefit, but I think the thing about probiotics to me is your gut bugs get set relatively early, and once you're you. And you can interfere with that maybe by temporarily with probiotics, but you're not changing your gut. If you want to have a sustained change in that, you probably have to change lots of other things as well. And so there are different ways of modifying your gut to encourage good gut bugs. And maybe that's more important.
What about fermented foods?
So people are interested in looking at it, and there's certainly groups within Europe that eat a lot of fermented food who have lower rates of atopy, but they have quite different lifestyles as well. Yeah.